Dear friends, I am Dr. Hemraj Chandalia. I'll speak to you today about a very important topic which you have to use in your practice, and that is how do you educate a patient on whom you have started insulin? And that gives confidence to the patient to then go for the therapy and successfully adjust the doses. So patient must know about the insulin you prescribe. Sometimes, the older time, they used to say transparent insulin, cloudy insulin. That is not acceptable. They should really know the name of the insulin and even the manufacturer. But name is clearly known, then you obviously know the manufacturer. And I think patients should be conscious about cost of the insulin. And doctors also should regularly see how they are costing, because some of them can be frightfully expensive insulins. And to my mind, it should be per unit cost, so the comparison is easy, because sometimes the vial is 400 units, sometimes vial is 1000, when it's U100 cartridge there are 300 units. So cost per unit is, I think, will be interesting for you to understand and tell them. And of course, the patient should know is short acting. That means it's probably meal related insulin before meal, and whether it is clear or cloudy mixture. Remember that all mixtures were cloudy earlier, but now we have what is called, and they require a resuspension by shaking the vial or shaking the pen, rolling the pen in your hand and mix it before injecting. So now, of course, there is what is called co-formulation, where a mixture is made, but the mixture also is clear because both of the insulins are being manufactured jointly. Then they should know how fast it starts working, because injecting correct time before the meal is very crucial in picking up the post-meal peak. If they inject at the wrong time or they eat immediately in a like human insulin where 30 to 40 minutes are required for the action to start, then it cannot catch the post-meal peak and you don't get good results. And you should know the strength. In the vials, we still 40 is available, U40. Cartridges are all U100. That means that to be measured in the appropriate pen. For cartridges, things are simpler because the industry gives you a pen which is matching with the cartridge inside. So U300 also, the pen given to you is matching with U300. So you don't have to make the dose 1/3 because it is concentrated. But the vials, you have to be very careful whether it's 40 units per ml or 100 units per ml. And I told you about what is called co-formulation, which does not require to be shaken or resuspended before injection, or is it a mixture where you need to resuspend it by shaking it. First of all, let us take human insulins. Human insulins are the least expensive insulins currently, and they are very good use if you know and the patient uses it properly. For example, the gap in case of human short-acting insulin between meal and insulin is at least 30, or in long-standing diabetes is even 40 minutes. Then only they are able to catch the postprandial peak. So human insulins, short-actings are there. We call it human regular also, and sometimes there are different trade names to this. And of course, human insulin, which is mixture, 30-70 mixture, you see, it is 50-50 mixture, and sometimes, even any other 25-75 mixture. See, so you have to understand when they are mixtures or short acting. The short acting are before meals, the mixture are usually taken once a day. Sometimes there are regimes where the mixtures also are taken twice a day. So it's important for patient to know what mixture they are taking. And then there are insulin analogues, which are usually 2.5 to 3 times more expensive, but they have an edge in certain matters. For example, the short-acting analogues, quick-acting analog, most of them start working either immediately or within 15 minutes is the peak. So they catch the meals much better. And if somebody is on multiple doses 3 times a day, to wait for half an hour or 45 minutes to inject and then eat may not be feasible for a person who is running around with all kind of activities. So, and of course, even the housewives at home may not be able to follow this kind of regime. So, analogues, it is affordable to the patient, are good because you can inject and eat. And there are even faster acting analogues now. So, they are like an aspart, and fast acting aspart also is there. So, they have certain edge. In hospitals where our nurses are not exactly follow this time gap between the injection and meal, we often use analogs so that no disconnection between the injection and meal, and you can get good results. Now, the patient should also have general knowledge about insulin. It's very important. How to manage insulin day to day while traveling, at home, how do you store? You obviously store in the refrigerator, not in the freezer. Even the refrigerator door is all right. And of course, you see, it can be stored safely till its expiry date. However, it should never be frozen. And remember, when people travel and they check it in a check-in bag, then it gets frozen when they're flying at the high altitude. And of course, they get all right when the luggage comes down, but their potency is gone. So sometimes you find somebody not getting control after a trip, after a flight, and then you should ask whether it was put in the check-in bag. Stability is good. Even at the ambient room temperature, the insulin pens can be stored unless the temperature is very unusual, like 40 degree Celsius, 45, 50, which happened in this last summer in our country in many places. There probably some kind of cooling is better. But otherwise, 1 month, there is a reduction in potency which is negligible, like less than even a percent, and therefore it doesn't make any difference. So in your clinic, in your office, for example, you can leave the pen in the drawer, but it should not be near heat like a glove compartment of the car or the car trunk where it can get heated during travel quite a bit. A patient must know sick day routine. What do I do when I can't eat? If I'm vomiting or I have nausea, I have a diarrhea. They have to know how to split, and please teach them and give in writing a paper stating the sick day routine. It is a good idea to do that. And of course, the total dose then is converted into quick acting, and instead of 3 doses, you make 4 or 6 doses and give small doses at a time depending upon the response on that particular day. Diarrhea is the commonest cause of hypoglycemia in our country, so remember that invariably you have to lower the doses, but otherwise in many of these there is infection, so dose required is large. Patient must know injection technique. It's very simple. But there are many aspects of this, especially like rotation of injection sites you don't show. They inject morning on one side of the tummy, evening on the other side, but next day morning they are in the same spot. So this is not rotation of the insulin injection. You give them 3 lines near the navel line and tell them to use one line for one day, 1 inch apart, 3 or 4 shots. And then of course, you see, so some of these things are very important in the injection technique. So I think they should be really demonstrated properly. And when you initiate therapy, the first way to break patients' resistance to accepting insulin therapy really is give one shot right in the clinic in front of you. You can probably use a pen with the dummy insulin in it, like saline cartridge in it, to teach. And I think this works very well. They realize that it is virtually 100% painless, and they have to learn about hypoglycemia. In fact, you should teach them about this and mark in your file that you have done that, because a bad episode of hypoglycemia in an odd place where patient faces a danger or accident, you may be questioned as to patient was educated on this aspect of side effect of insulin therapy. And although there are ways of using insulin without causing hypoglycemia, which sometimes I describe in detail in my lecture, but even so, hypoglycemia is a reality, and I think you must prepare the patient to what to do in hypoglycemia. So more about the storage of insulin: protect from direct sunlight and heat, and of course store in a cool, dark place if you don't want to refrigerate. And I told you about refrigeration and not freezing. And what you're using, that insulin vial or cartridge or pen, can stay at the ambient temperature in any drawer away from heat and sunlight. When you are traveling, obviously in the handbag always. And you see, if you are taking a long travel, and then take it out of the refrigerator and put in a cool pack. And in the car, it should be inside and not in the glove compartment or trunk. Now, technique we are told you have to see carefully and really should be taught systematically. There are websites for this. You can tell patients who are good with the internet to really see those in detail also for themselves, and of course be sure about rotating injection sites. And there are some issues which arise day to day when you teach insulin therapy to your patient. Patient has to know insulin regime and how many doses a day, what time before meal, all that they should know. They should know the dose correctly. Many of them don't have even the exact idea how much they are supposed to take. The self-titration of insulin dose is possible. This has been tried with great success, but it should be done most of the insulin every third or fifth day. You cannot do it after 2 weeks. You will not be able to titrate for several months, which is a very great help to the patient. And patient can participate in this, how much increment in every third or fifth day, and they sometimes manage it quite well. Sick day regime, as I told you, they should know. You see, some malfunction of devices and pens is there, and needles is there. So needles have to be changed after at least 3 use. Technically only single use, but 3 use is about the maximum. Anytime there is pain means the needle has to be discarded because it has been slightly damaged. The point is really damaged. And measurements, they must know their doses correctly and on the pen or on the syringe. And syringe, hyper and hypoglycemia, changing that insulin with hyper and hypo, they should have an idea. They had an episode of hypoglycemia just before lunch, and should they really take the lunch dose? So obviously they first are given some food to recover, and thereafter you really let the patient sit for the meal and you inject just before the meal. Preventing nocturnal hypoglycemia is very important because the responses, the counter-regulatory responses to nighttime hypoglycemia when you are recumbent, they are not very efficient, and patient may not recover on their own easily. Sometimes there is a lot of hypoglycemia, they'll go deep into coma, and that will be disastrous. So nocturnal hypoglycemia, common in elderly people, common in people with long-standing diabetes. Patient has to be taught about nocturnal hypoglycemia because it is very unpleasant event and sometimes dangerous, because counter-regulatory responses at night in the recumbent positions are not as vigorous or not as fast. Probably a snack at bedtime may be added in these people if there is recurrent nocturnal hypoglycemia, and the insulin doses, especially the short acting before the dinner, has to be reduced, or human insulin may need to be converted into a fast acting analog. Now, another important point is how much time before a meal a particular insulin should be injected. And here we see quickly the human insulin, as I said earlier, 30-45 minutes before meal. Rapid acting analogs about 15 minutes before. Some of them ultra rapid, so maybe just before meal. It is said they can be injected after meal, but ideal time is still 15 minutes before meal. Long-acting analogues, also called basal insulins, which usually cover 20-24 hours of the day, they are given at a fixed time. So only insulins which are related to the clock time. There is glargine, most frequently used long-acting insulin, which is less expensive than any other. The flexibility it offers is plus minus 1 hour of time, you see, to inject. And then other ones like ultra long Tresiva offers you flexibility of plus minus 4 hours. So these all ideas about how to manage day to day, they have to be passed on to your patient when you start insulin therapy, so that patient can grapple with the problems on their own and do not need external help, which may be difficult to access in some emergency time. Thank you very much for your patient hearing.